which is a vomiting dogs. Okay, so as usual, I suggest we start with this one, which is Tassi. I will open the images and then in a minute share the link so you can open the images in your computer. So it should be this, and then I'll go to the web. Okay, close topics. So it should be case number. Let's flip it and start with case 85. And I'll share now the link. Copy. Chat. Paste. Okay, so there you have the link. Oh, I'm sure you can't see my screen because I thought about sharing, but I never really share. So hopefully you can see my screen now. Hopefully you have the link to the images. So we should be all ready to go.
Yep. Got them both. Thank you.
Oh, no. And then what is missing is I need to give you some kind of information about the patient. So the history. So let me share that. So this is, I usually share exactly what I get, kind of to make it a more real situation. I'm sure you would love to have more information. This is not a very unusual thing. Usually imaging is one of the first things we do. So usually we have not so much information. So this is I made up the 9. I got like an old Jack Russell. So I think like a 9, 10, whatever. Anorexic. And it doesn't say there, but they told me that it was a vomiting dog and they suspected there may be some pancreatitis. Or the pancreatitis was a differential diagnosis at the time. Okay. So these are the images. And we do the same thing. Take a look, and then I take notes of all your findings. We see if we all agree on them or not. And then we see what we recommend and how we interpret the abnormalities, if there is any. My paper. Okay, normal, abnormal.
Abnormal.
Okay.
Abnormal.
Good.
Definitely abnormal.
So now the effort should be in trying to describe, and hopefully now with having discussed many cases now, we're close to 100 cases, which in each of them we spent almost like an hour. Hopefully the description shouldn't be a frightening thing because it all comes down to, we locate something and then we talk about morphology, which is something is big, small, in the right place, is in an abnormal place, or size, shape, contours, opacity, and location. Makes sense? So we can bring the description, and I think that usually help us also see things if we know how we're gonna end up classifying abnormalities. So after a while, the description in a radiograph turned to be almost like a boring thing because it's almost using the same. One day I'm going to share, there is a book about how to write reports in radiology, and they insist about being boring because the important thing is to communicate what is abnormal, not to be very, very colorful in your descriptions or whatever. So, and then it's almost always the same. Obviously, the radars are different, and what we are looking at is different, but how we approach it is always the same. Okay, so what do you see?
Okay, there's The liver is well defined.
Yep.
The spleen a little bit less so, particularly dorsally up there. Whoops. A generalized ground glass appearance of a lot of the rest of the abdomen around sort of there, basically.
Mm-hmm.
Okay, and I'd agree with Jeff. I can see a loss of detail. I think particularly in the cranial abdomen, I can't see the outline on the lateral, the outline of the stomach very clearly, although I can see some gas in there and the alignment might be okay. I can see gas in what's probably the cecum and a little bit of gas in the colon, but I can't see a lot of gas elsewhere, and the definition of the intestines seems to have disappeared.
Okay.
Sorry, can I go on? Yeah, right cranial quadrant. You've got, I don't know.
You go on and off for some reason.
Oh, I know why. It's because I'm pressing the thingamajig button. Bear with me.
Technical issues.
Mariano, I think the DV needs to be reversed.
Oh, I don't think so.
Unless they marked it wrong.
Okay, so where can we go when we have a situation like this? In the distal limb, things are so symmetrical that we don't have an anatomical help. But in the abdomen and the thorax, unless there is a congenital abnormality in terms of positioning, like situs inversus or something like this, there are asymmetries that we can rely on. So one of them is the calva vena cava. So I think the calva vena cava is here and should be to the right.
Yeah.
And then the other one is the spleen. So the spleen is there. The other one is the left kidney that is more caudal compared to the right. So I think the border of the right is there. The border of the left is there. So the spleen should be on the left, calva vena cava on the right. I think that's the fundus of the stomach. So once I find all of that, I can confidently say, you put the marker wrong.
Okay.
Okay, so as a summary, I want really someone. Okay, yeah, cool. I see. What do you think about that? Someone is drawing something on the right cranial quadrant of the abdomen. I think it's Jill, but I think you're struggling with the microphone.
It is me, and I am struggling with a microphone. I seem to have lost part of my thing. Can you hear me now?
Yeah.
Okay, that was me who drew it. You've got a gas opacity, and it's more than just a gas. It's like a stipple gas opacity in the right cranial abdomen. And yes, I'm worried that we've got ground glass appearance. I'm worried we've got peritonitis, and I think we've got gas in that area there. That's what I was going to say.
Okay, so I keep writing, and then hopefully we have people adding or disagreeing or bringing more stuff, and then once we have all the ingredients of the salad, then we mix the salad. Okay, so I'm kind of waiting. So for now we have the liver is okay, the spleen is kind of okay. Maybe some of the borders are not that well defined. Then I think now there are comments in agreement that there is something wrong with the detail. I think you call it ground glass opacity or something like that. So, and then there is something that is gas tubular, I would add gas field in the right cranial abdomen. So we have those, let's say, 4 findings.
I don't know if I'd agree about a ground glass appearance, to be honest. Certainly a loss of detail in this area, but I don't know if it's ground glass. I feel like all of the reduction in, or the mottled opacities look like they're intraluminal on the VD and the DV and the lateral. But I think something that we haven't mentioned is this here, or maybe this, I'm not sure where the borders are. I don't know if this is the bladder or if this is the top of the thigh. I think it's the bladder, in which case, I don't know what this is. It's got some soft tissue and gas opacities. It's round. And it may or may not be connected to this area, which is sort of slightly mottled soft tissue opacities. And I can't see this, I can't discern these two structures on the DV. There is, I guess the reduction in detail is a little less obvious on the DV. I'm also interested in this soft tissue opacity here. I don't know what it is. And interestingly, you may say like this gas opacity here looks like it could line up with this possible bow here, but it doesn't quite. So I don't know what it is. I don't think it's I don't know. I don't think it's to do with this. I don't think it's related to this intestine.
Okay, beautiful. So I think you really moved us forward or backwards, but you moved us. Makes sense. So you are bringing new stuff and you are challenging previous comments. So perfect. And now then the idea will be now to see what the others, first, how they react to your findings, and the same thing that you've done, if they agree or disagree, or they help you move forward, or say, no, you are reading something really wrong, and we go backwards again. So
When
I see exactly what you mean. So perfect. Yeah.
When I said ground glass, I wasn't meaning to be specific. I mean, I should have said loss of detail, which is a more radiologically suitable comment. But the other thing that I'm interested in, and it might just be positioning, is that the tail is got quite a bend in it, and it may just be positioning. But I'm wondering, is there something in is there something in there that you know?
Okay, so we had another thing,
Like
let's
that.
call it in the pet, or maybe in the pelvis. So yeah, we are still bringing all the ingredients of the salad, and then we will need to decide what we keep, what we move, how we put things together. So yeah, perfect. We are in that process where we bring abnormalities now. So any more new stuff, someone that wants to pick on those things or whatever we've said and either support or bring an argument why you disagree?
Well, actually, what I'd like to do is put my finger in there and see if that's a real finding or not. Because if it is, it might be a prostatic tumour. If it's not, well, we can look elsewhere.
Okay. Okay. So, well, we can, if there is, if there are no more comments, and suddenly you are shy today, then we can try to start making hypotheses and saying, well, this is what we see, this is the problem that I have, but this may be this or the other. Makes sense to trying to find. So that was one, and say, well, if that is abnormal, then the way that I would go forward is I would palpate, and then because the thing that I have in mind is, well, there can be a mass and could be in the prostate. So I don't have a, so maybe now it's time for me to put something out there. So that is not, it's a weird, a weird looking tail, but it's not an unusual looking tail, and I'm not that concerned. And probably something else that I would, even if I don't have that based on experience, I would say, well, if that is real, then I would expect the dog having some issues more than vomiting, defecating, and then I will probably immediately I will go and see if that is real and there is such a big mass. Then what about the colon? Is there a lot of feces, you know, stuck in there and then waiting? Is there constipation? Trying to bring supportive information, trying to bring something that will help me support that hypothesis. So I don't see that. And then if we go for a prostatic situation, I think, I'm not saying that is always the case, but mostly when the prostate gets big and in an older dog, it's going to be more abdominal. So then probably I would expect, yeah, something more in that area rather than that colic. I'm saying that's not always the case. For example, a paraprostatic cyst usually looks like two bladders, but you know, if a tissue is abnormal, why cannot go to an? Usually it follows gravity. So if something gets big and the prostate gets big, usually goes more into the abdomen. Another thing that we could be thinking, and it would look like something in that area, would be a hernia, perineal hernia. But there we probably wouldn't expect to see the contour of the bladder that well. It could be that the prostate is going there and then it's here. I haven't mentioned, but the dog I think is not an entire dog. I don't know. That doesn't mean that it's less likely to have a neoplastic prostatic neoplasia. So, but probably less likely to have a hernia. Okay, that's kind of my answer to that thing. Is there anyone willing to take on that and try to say you agree or disagree or support that, and I don't know, try to push that idea about this? Or what could it be? So we said it looks odd. I don't know if I can continue that with this tubular structure. So even though we have those difficulties, you know, what could it be? Can we hypothesize, even if it's not a perfect situation?
Yeah, I agreed with Bron when she pointed it out. I thought, gosh, what is that? Is that an end-on transverse intestine that we're looking at? And does it have, say, foreign material in it? So Jack Russell, they tend to eat things that they shouldn't, although it's an older one. Then I was thinking of something like an intussusception. And initially when I saw it, I thought colon, but then the gas dorsal to it should be the colon. And as Bronner has already pointed out, it's not really in the area where the colon should be. It's too ventral. So that's what came to mind, was some kind of soft material, foreign body and intussusception, something like that. But again, its age is unusual for both of those things.
So, I mean, let's say you're working with this dog. How, if you need to weigh your certainty about these findings, so you say, how certain are you that it's abnormal? I like your consideration about what it may be, because its gas field is tubular. So I think we have the right to say it's bowel. Then the next step would be, is that colon? Because if that's colon, then what is inside could be feces. Usually feces, they have that kind of a shape, and then there could be gas around them, different from the small intestinal content, which is more fluid. So in the small intestine is very unusual to have that separation between the border of a luminal structure and gas outside, just because it's fluid. So either we have fluid-filled bowel loops or we have gas-filled bowel loops, but we don't have that. The second point that I will make is the diameter. So how are you going to use the diameter to decide one way or the other? So I like it. So I think we should go ahead with the idea that that's bowel. I think we should go ahead and say, then now I'm interested in you saying, how certain you are if that's colon or small bowel, because then that is going to guide us to go forward. Yeah, so how certain are you? I like that consideration. Is this small bowel or colon? How certain are we that this is small bowel? You mentioned that you can see the colon, the descending colon there, and I agree with you. How if this
Pretty
small
certain.
colon,
I think it's
how certain
think
are
it's-
we? How certain are we?
very certain.
Okay, cool. So then if we are very certain that small bowel, let's continue on. What are the options? Is it normal? Is it abnormal? What can be wrong?
It's
guess,
very dilated.
Yeah.
Absolutely. So, yeah.
Yeah, it's very dilated. And I guess what I'm thinking of, as I said, differentials of foreign body obstruction, interception, then I question, well, why aren't I seeing more gas or rad to it? So I question myself going, oh, well, that doesn't really make sense, if it's, unless it's not a...
Excellent point. So you're really tackling all the points. I'm glad about that. So we found something in the beginning wasn't easy to find, but then we found then we built confidence in trying to identify what it is. I think now there is, because of the shape, because of the opacity, because of the location, we kind of feel more confident that that's small bowel. And now you are going forward. You are saying, well, if that is small bowel, well, I expect it to be more gas filled. I don't know how you resolve that problem, but then you are saying, I would expect to have an accumulation of fluid or gas in the rest of the small bowel, and I don't see that. I perfectly fine the definition of the problem. How are we going to move forward? I understand the problem. I want to see your reaction to that, because your expectation is perfectly fine.
My reaction would be to pick up the ultrasound probe.
And where are you gonna? So I usually, when they bring a vomiting dog and then they want me to do an ultrasound, my reaction is, do you have radiographs? Because it can kind of guide I know that I'm gonna scan the whole thing and I'm gonna be systematic and all of that, but having a radiograph is gonna direct my search. Makes sense? So I'm gonna say, well, looking at the radiographs, I can rule this out, or very unlikely, and I think this is the problem. So I'm gonna put the probe there, and I'm gonna try to solve the problem, and then I'm gonna complete the ultrasound to make sure that I'm not missing anything. That's perfectly fine. But so I understand your situation. I'm gonna go and grab the probe. What's the question that you want to answer from these radiographs? Where are you gonna go and put the probe? What's your hypothesis? What is going on?
As you said, just differentiating between, is this small bowel, large bowel? We think it's small bowel from its positioning. And then I would confirm that with the architecture of the bowel with my ultrasound probe. Is like, right, okay, I know what this is. And I guess then looking for signs of, is there, what's the motility of the gut? Does there look like there to be a foreign body? Is there a interception? I guess I'm trying to A, work out anatomically what it is, and then B, get some more information about what it is that's causing the pathology.
I see, and I have no argument against that. What I'm probably saying is, be aware that you are getting into a tough ultrasonographic question,
Mhm.
because you are dealing with the GI, and then you are trying to differentiate colon from small bowel. I'm not saying that you can't do that. Certainly you can, but you are getting into probably the most difficult aspect of abdominal ultrasound, which is dealing with the GI tract. So
Particularly with gas, hey?
absolutely. So I'm not saying don't run that in that direction, but be aware that you may have the answer right away in front of your eyes, and then you may not need to go to something that is so complex. Okay, so
I was just going to say, well, now I'm concerned that the gas I was looking at before may actually be sitting. If you imagine that mass that you can see on the lateral, you can see on the right-hand side of the BD or DV, you could, that gas opacity I was looking at, is that not possibly sitting in front of a long?
okay, so now you're saying this may be oral to this. Is that what you are saying? Yes. Okay.
Yes,
Okay. Cool.
yes, it is what I'm saying.
Awesome. So then, have you solved the puzzle? The puzzle that we are dealing with now is that, I think I insist, we went through different considerations, and I think we all agree that there's something abnormal in the bowel, is likely in the small intestine, the content is abnormal, the diameter is abnormal. The puzzle that we are dealing with now is, why is that there is no, this seems to be the opposite situation that we deal with many times, where we see the consequence of the obstruction. We don't see the cause of obstruction. So now we are seeing a distended bowel loop. We don't like the opacity. We don't like the diameter. We think it's small bowel. The puzzle here is, why is that we are not seeing? Someone could argue that just the dilation of that bowel loop is already a feature of obstruction. But there is this extra question, which is, why is that I don't see the rest of the small bowel very distended? And now you are saying, well, maybe these two are connected. So yeah, move that forward. Go on. How are you going to put things together? How is that helping you?
So there's two populations of bowel, I guess. There's small intestine that looks normal in this area, and there's some small intestine that looks abnormal, which is, well, actually, I don't know about that line. Definitely here, and possibly anything in this area which has a reduced detail. And this here could be large intestine that's just pushed a little bit more cranial than normal. And it's not at all connected to this here. So it may well be that that's just bowel and this is small bowel.
Cool. Any other hypotheses? I'll probably bring, or try to, probably there is enough of me being quiet and not let's say solving the puzzle, but I want to give you the opportunity, because you move forward. So in the beginning you didn't see the structure, then you saw the structure, and then we went to the small bowel, and then we are still struggling with the connections and what is abnormal and stuff like that. I can solve the puzzle, but I'm also happy to give you the opportunity to move it forward, because otherwise.
Sorry, Mariano, do we know how long the dog has been vomiting for? And I guess it goes back to the question of
one day, I think 1 day or something like that.
So it's quite acute. It goes back to the question of, well, how long does it take for the gas to accumulate rostral to the obstruction? And has it just not accumulated yet? Or it's a long shot, but I'm just trying to think outside the square a bit.
Is it just that it's close to the stomach and the dog's vomiting, so there's not that much intestine to fill up with gas?
Okay, perfect. So that's one of the reasons, that's one of the situations or the exceptions to a rule. Do you remember that we said we have these two populations of bowel, there are exceptions to the rule, and that happens, the ideal situation is when you have something obstructed in the middle, whatever is oral to that gets distended, whatever is aboral to that is normal or empty. And we say, well, be aware that there may be the situation where there is something very oral and makes it very close to the stomach. And then that's basically you're going to remove, and the hallmark of that situation will be a pyloric obstruction. So it's still a mechanical obstruction. Makes sense? So there is a mechanical obstruction of the passage of content through the GI tract, but the whole small bowel is going to look completely normal. So be aware how we use the rule, and be aware about the exceptions to the rule. So that's a perfect comment. So what if this is very oral? And then basically, and now I'm gonna unfold it, what I think. So what if this is duodenum? It's on the right. I think I can connect it with this. This is going too cranial, too much on the right, and I think I can follow that line. If not, I pretend, but everything fits in place if you just assume this. If this connects with that, and this connects with this, then this is the only portion of the GI tract that is distended, which is the most oral portion of the duodenum. So if you have that model, if you have that hypothesis, everything fits in place. The structure is very elongated, it's on the right, where we want the duodenum to be. It seems to be connecting with a gas field structure in the right abdomen. So the only question that will be is why the stomach is not distended. And then the answer we usually give in a situation like this is because the dog just vomited everything. Makes sense? But then we have the explanation why the rest of the small bowel is completely normal. So, and then in terms of prior comment about that, I think we talked about a case. I need to look at, let me see, I think the idea of an intussusception is a nice one. I think we got a case on intussusception case. The only thing that I would say about the idea of intussusception, now if you go into what could it be producing the obstruction, if we haven't, I would bring the intussusception case because it's a beautiful case that I haven't really, if you remember how it looks, you never forget. It never looks that irregular because remember there is one bowel loop inside the other. So the borders that we see, and usually there's not a lot of gas because there's a lot of pressure in there. So basically it looks like a perfect, like a real sausage. And then the opacity within that sausage is not, it doesn't have a lot of gas. You can see the obstruction oral. So I think this is telling us, first, there is no fluid because it's very distended. So I think the differential of a foreign body is way, way, way high in the list. Okay. So I tell you what happened because I know the answer, and that's why I brought this one. I was pretty sure this was a foreign body in the duodenum. So I had no question that this dog needed surgery. Almost no question that that's a foreign body. I mean, I think the differential could be a neoplasia in the duodenum. Yes, and the dog went to surgery, and there was a foreign body in the duodenum. So,
well done.
I like the exceptions to the rule because I think the classic cases are a bit boring. So like exceptions to the rule are, I think the exceptions to the rule also help understand the rule. So that's the reason. So this is somehow an exception to a rule because, you know, when we think about obstruction, we think about these two populations, and that's what we want to remember. This one is somehow breaking that rule, but I think there are beautiful features, and I think we picked them up. We picked this up, we connected. I think another thing that we were doing, and this is not to criticize, but to to try to help you move on, and it's a very understandable thing. We use these lines, so for example, that line, and then we say, well, maybe that's stopping there. Remember that the price that we pay to have a three-dimensional structure reduced to a two-dimensional image is we have plenty of images that they are just superimposition. It makes sense. So this line that we see here is very likely not within that tubular structure. Is something that is superimposed, like a vowel loop, like similar case like here. This is a vowel loop that we don't know where it goes here, maybe that way, and maybe here this way. And then we are making up maybe something in the middle, so it looks like a mass. So that is the price that we pay for having something so cheap and easy to do. And the price is quite big. Makes sense? We have a 3D object reduced to a 2D image. And most of the difficulties that we have reading a radiograph is dealing with that issue. So, for example, now that I pointed that out, probably it's easier for you to see, well, actually that line goes like this and continues. And now that I show it, it's there. I mean, that's a clear thing. And then this, it goes across and it goes over. Makes sense? So it cannot be part of that structure. Am I saying that that's easy? No, but that's the fun for radiology. It's trying to unfold, undo all the images, and then be aware of all the limitations and what could happen, which is also always coming back to the grapes. But the grapes are easy because we know, we have an expectation about the grapes, how the grapes, what's the shape of that grapes. Now we don't know. And then, so the tools that we have is, when we have a line like this and we want to stop the tubular structure here, you know, the tool that we have is, can we continue that line outside? Makes sense? And by doing that, we are saying, well, that's not part of that structure. That's something that is superimposed. If you don't like that, you don't like radiographs. That's what we love about radiology, which is once you can untackle that limitation, it's kind of fun. But we hit our head against the wall all the time, and we deal with it's always the same. It's a poor contrast resolution, and it's a 3D object reduced to a 2D image. And we deal with that 100 times a day. Okay. Hopefully, you know, the whole idea of spending time and reading radiographs and spending so much time in discussing just lines and ideas is that hopefully now with all that knowledge, if you look at the image again, you can unfold, you can interpret those findings in a different way, and you have more tools in your toolbox next time you deal with a situation like this. Makes sense? So next time you are saying, I see that looks abnormal, I think it's tubular, I think it's not going to look the same, but probably the problem is going to be a similar problem. And then you say, well, no, not too many vowel loops distended. Now probably you can reach that memory a lot easier and say, well, it may be that, you know, it's an upper obstruction. It's very, very oral. I mean, that's the whole point. And I'm sure I mentioned this, but I think learning is the experience. So it's not only the knowledge, but having struggled. That's why I let you struggle, because I'm sure you had the knowledge. I mean, the theoretical knowledge about if it's an oral situation, an oral obstruction, then there's not going to be vowel loop distended. But it's the ability to recall that and to bring that when you are seeing it. So that's why I let you struggle, because that should be a learning experience. Okay, any questions? Hopefully we managed to get a balance in between frustration, which I let go when we are stuck in an idea, and then also the happiness of putting things in order and being able to explain what is going on and seeing it. And I think if you get that balance right, then that's a good, let's say, energy to keep on learning.
Yeah, perfect,
Yep.
Mariano.
I
Thank you.
agree.
I agree too.
Mariano, not relevant to the current situation, but what would you comment about the abnormality of the cortices of those two femurs?
Well, so my reaction to that would be is symmetrical. So then it's not going to be trauma it's probably not acquired. It's probably a variation of normal. It's somehow a contrastrophoid dog based on the relationship in between the length of those limbs or those femoral, and then the abdomen or the overall size of the dog. So that would be my reaction. And then probably the other reaction is, so it's bilateral. And then the other reaction is if I need to define that, it's just a little bit of a thickening of the cortex. There's no lysis, there's no newborn formation, so it's not aggressive. So it's bilateral, no aggressive. I'll probably ignore, put it to a variation of normal. I really enjoy your peripheral. You go around, and I need to say that that's another chapter, and it's probably more. I don't know if that comes across when we have these rounds, but well, it's coming across with your remarks. I think personality-wise, and I don't think this has been studied or whatever, but I've seen over the years, and I've seen it myself. Kind of two situations, or I'm gonna put it black and white. I'm sure it's not black and white. I'm sure they're grays. It's like people like dealing with the issue first. So basically, they want to know a lot about the history. It's a vomiting dog. So basically, they are just about answering that question. And that's perfectly fine. But the risk of that approach is that that approach, no, it's not a person, it's an approach, may miss important things that are peripheral. So that I'm not criticizing, it's just the definition. Makes sense? So if you just go to the problem, you focus, then you may miss something that is important that it wasn't in your focus. And again, it's not a criticism, it's just to be aware of your approach. And then the other is to do the opposite. Is to say, I don't want to know anything about this case. I just want to look at everything. And I'm gonna go first, the very uninterested part. So I'm gonna go on the legs, I'm gonna go on the spine, I'm gonna go on the thorax. And I know that this is an abdominal radiograph. So I'm not gonna go in the center. And then at the end, you go in the center. The problem with that approach, and again, it's not a criticism, it's just to be aware how it works, is that you may find many things that you don't know how to explain. And then that may stuck you and may divert you so far, so much, that you never really tackle with a question. So I realized that I'm the first. I realized over the years that I want to solve the case. I want to know what's going on. And I know my limitation. I know that if I let that go unchecked, I may be missing important things in the periphery. So because that is my nature, I force myself to be the opposite first. So if I'm really dealing with a difficult case, I let the animal go. Makes sense? So I try to solve the case, but I never sign that report or let the person that is asking me go before putting myself into the other situation, which is let me for a minute go the opposite. Let me for a minute go peripheral. Let me for a minute go into the small thing that is going on around. So with this, I'm not saying that this is a right or wrong way. I think I'm trying to paint, what I think are extreme situations of what can happen with our attitude towards the cases and how to recognize the weaknesses. And probably over the time, you can recognize how to deal with that. Mine is, I let the animal go first. That's my nature. I want to solve the problem. I don't see anything that is in the periphery. I put all the energy in the center, but I force myself. I never go away from the study if I don't, for a minute, take the other approach. And I've found so many important findings. And I remember finding things almost about sending the report. So I'm done with the report. I'm tempted to say, get out of me, get out of in front of me. I'm gonna send it. And then I always stop. And then I look the periphery, my weakness. I go through my weakness. And I can't tell you how many times I found a small thing that it was so important to the case. I need to write the whole report again. many times. So I'm not saying, I think it's just seeing and learning how you operate, and then again being aware of the weaknesses and the strengths of that. I think there is a strength in that attitude, in that you really put all the energy to solve a problem, and you are really focused on that. But there is a weakness to it, so you need to be aware of it. And the opposite, I remember someone during my residency that even physically he would stand on the back. So we were all discussing. We had what we call hot chairs. So once a week we sat in front of a bunch of cases, and we need to give our opinion in front of the rest of the group. And it was called hot chair because the chair is hot at that time. You know, you are on the spotlight. And then there, when you're under stress, your real you comes. Makes sense? So for me, it was very easy to focus and concentrate. And at that time, it was very hard to learn to do the opposite. Again, because you're on the spotlight, and there you have less room to play. And you are a student, you are a resident. So you know, all of that comes into consideration. This guy would go on the back, and he would always point to important small things in the periphery. He had that attitude. He had that approach. I don't know if it was the way. I don't know if it was a self-taught situation that he made many mistakes and then he focused on that. Maybe he was very relaxed and having fun seeing us stressing, and then he would start and then identify and say, "Have you seen this? Have you seen this? Have you seen that?" And there were all things in the periphery, all very important. So again, I think that's probably a next level if you want, but it's important to be aware of again I'm probably you redefine them, but I think I can identify those like this. If you are focused in the center, that's a good thing. Be aware of the rest. Some people have the opposite approach, go peripheral first, and then only then they go to the center. It's the same, but I think as long as we're aware of the risks or the weaknesses and strengths of each approach. Okay, that was a lot of me talking. Anyway. So I suppose we leave it here because there's not enough time for another case. There's another case which is there are some connections to this case, so they are in the same group, but we can deal with it next time.
Great, thank you, Mariano.
Yeah, that was very good. Thanks, Mariano. And the saying you need to have is the devil's in the detail. That's a saying that people always tell me, is to remember to look at the small things in the periphery. The devil's in the detail. Yeah.
But there's also a nature. So for me, I need to learn that. That wasn't in my. Interesting, yeah, because I love the detail and I love the situation where I find a small thing that changes. For me, a cool case or a case that makes me have fun is a case that probably something not that obvious, that something small is very important. I love that. Right? It relies on that small observation. I think probably we're mixing here the center with the periphery, or the detail with a big thing. I think I'm able to find small details if easily, and if that detail is related to the question in the case. Makes sense? So you have a vomiting, that for me is the trigger, is the solving the problem. And then in that, I can easily find the detail. My weakness is probably in a vomiting dog, where we see this, is have I checked all the vertebrae to see if there is a met? Have I checked all the ribs? Have I checked the lung to see if there is a met? Is that important? That's blood important. Because one thing is to send this dog to surgery because it's a foreign body, but this is a 10-year-old dog. So is there anything else that is going to change the overall approach? And it's in front of my eyes. So my nature goes to solve the case, and then I feel like relaxed and say, well, and I think we all have that. Like, okay, now it's a foreign body, it's like in the duodenum, every piece fits in place. that brings a lot of satisfaction and say, well, phew, now I think we can explain everything. I kept on building my confidence. I sent it to surgery, whatever. And then probably the thing that I, based on experience, now I don't let go. Before I send this dog to surgery, I physically make this image small. And that helps me to see, well, no, big picture approach. It's an old dog. I'm sending this dog to surgery. I need to go fishing. You know, then maybe something else. And then I go and make sure that it's not in my nature. It's not the first reaction, but then it becomes almost like a second nature. When if you do it enough, it's like an approach to the case. I let the animal go first, and then I go more systematic. I'm sure there are different people have different approaches. Yeah, I remember probably because I was so aware of this weakness during my boards. I think I flipped it. I said I need to make sure that I don't miss the periphery. So I remember I changed and I started with the periphery because I trusted so much the nature, my ability to deal with the problem. I said I'm not. It's not that I was overconfident, but I said that's not going to be my issue. I know my weakness, so let's go through the weakness first. So I think I changed that sometime. Now I'm more relaxed and I let it go. But I try never to let a case go without. And that's probably, I mean, people working in the clinic, they may realize and then may also be a bit upset with imaging people that we change our mind. One thing is looking at a CT as it comes, and that is basically dealing with the problem. Makes sense? So this vomiting dog or a dog with a mask, and this is what we see. And then we have a very different approach when we go to our office. We sit down, we try to find more evidence, we try to put everything together, and we try to go in detail to very non-important things or peripheral things. And once in a while, we find something that it was unexpected. It wasn't in the question. It wasn't nothing that really changes the thing. And we need to stand up, go to the clinician and say, look, do you remember that I told you all of that? Yeah, well, now I found this. That is small in the periphery, and this changing the whole thing. Sorry, the dog is already awake, the dog is home, whatever, but now we need to change the whole approach. And this is how we deal with the images and how we deal with the cases. I think this is common for many imaging people. Anyway.
Mariano,
Any questions about the case?
Not on that case, but on that principle. In medicine, the idea is to find every abnormality and investigate it. And many times I've got the diagnosis like you by investigating something simple and peripheral. Mm-hmm. And that's why I asked about the bend in the tail, which could easily be just positioning. But while the dog's sedated for the x-ray, very easy to put a finger in and put it to bed, or
absolutely. And that's why I said I enjoy that. I enjoy your points. You are bringing that angle to the discussion. I'm also aware of the difficulty with that, because sometimes being able to drop things is as important as following things. Because if you don't let anything go, then you may spend so much energy in things that they are small. So, and I'm not going black or white. I'm not saying you shouldn't follow any of those. I'm saying that there is a point, like for example, the comments that you made, I didn't say I disagree and stop. I seriously took them and I elaborated them. And I said, this is a good idea, and let's continue. And then until I thought, well, now I think we have, even though it was a good comment, I think we have enough evidence to say, let's drop it, because otherwise we're gonna go in the wrong direction. But again, both attitudes, the balance is the secret, and there is no school for that. That I think is just doing, and yeah. But being aware of both, And in my mind, it's not being a big fan of either. It's absorbing both. It's taking the benefits of both and knowing the weaknesses of both. Beautiful. Back to life, back to work.
Thank
Thanks,
you. Have a good
Mariano.
day.
Yeah, bye.
Bye, everyone.
Bye.